All right, everybody. Thank you for being so persistent, and I'm glad to see that there's still so many people present. I'm glad we got this going. It's a great honor to have Professor Ghulam Fayyaz from Pakistan with us, and I'm glad to see, Ghulam, that it worked well to get this PowerPoint presentation of you on the screen. So thank you. It's wonderful to have you here. It's a great privilege for you to share knowledge in a fantastic way. We've known each other for a couple of years now, and I'm always amazed by what you do and what you can do. And I think many of us look at what you do and it looks like you're a real magician, but please help us to try and prevent those big holes. Once we have them, try and help us to try and solve those fistulas in as safe way as possible. So it's a great privilege to give the floor to you. I think it's best that we keep the questions for at the end. So normally it works like this. We have like 45 minutes a webinar and then 15 minutes to ask questions, 1-5. So let's try and do that. Ghulam, the floor is yours. Thank you. I think, are you there, Ghulam? That's a real pity. I just thought we had Ghulam ready and going for us. So we'll have to entertain you all a little bit more. But I'm glad he got his PowerPoint going, so that just shows that the security checks and everything are okay. He has the ability to share. I see some people raise their hands, but when I look in the participants list, I cannot find them. Afifa Ayuni, I'm sorry, I cannot see you here. Afifa, you have a question for us while we wait. Okay. Then we give the floor to Muhammad. Yes, Muhammad, the floor is yours. Dr. Usman.
Please, Manchester Piccadilly.
Can you see my screen now?
Yes, we can see it well. Thank you. This is great. Thank you that you've joined us again.
Okay.
So Dr. Ghulam, I've just introduced you to everybody. I'm not sure if you heard that, but I'm glad you're here. So please, the floor is yours.
So I would like to apologize to all the friends who have joined us from all around the globe. It's my negligence or my weakness that the meeting started late. So my topic of presentation today is prevention of cleft palate fistula. But if they do happen, how do I repair them? So I'm member board of the Interplast. I have been founder of the Cleft. I have been former president of Pakistan Association of Plastic Surgeons. I'm international volunteer surgeon from Operation Smile. This is my mentor, Professor Khalid Durrani, who trained me in plastic surgery. And my disclosures, I published a book with Springer, Surgical Atlas of Cleft Palate and Palatal Fistula. This is a 109 chapter book. Most of the patients I am going to show you are operated with the help of CCI, Cleft Children International. Other patients were supported by Operation Smile USA and Smile House Foundation Italy. So this is the first of the patient I operated for Prince Smile in Rwanda 2013. So in my presentation, you will see three important things. We always go for complete closure of the nasal layer, even in large palatal fistula. We do radical dissection of the pedicle, and we use continuous suture for the nasal layer as well as the oral layer. So what are the complications of palate repair? Immediate may be post-op bleeding, airway problem, and late may be infection, dehiscence, fistula, and velopharyngeal incompetence. So can we prevent the fistula? Yes. We need to do adequate release of mucoperiosteal flap, radical dissection of the pedicle, pinpoint electrocoagulation of the bleeder, and we need to have good quality surgical instruments. And if the fistula is going to happen, what can we do? We need to use medical grade honey 4 to 6 times daily with plastic teaspoon or tablespoon, and avoid swelling of the honey. Keep it inside the mouth, and nothing else is allowed for 15 minutes. The fistula may close on its own, or the size may reduce considerably. So what is medical grade honey? This should be organic honey, not synthetic honey. And we usually test it at the microbiology lab. We grow the colonies of Staphylococcus aureus and put a honey drop into it. If the zone of inhibition is more than 15 millimeter, it is medical grade honey. So what are the factors which can affect the fistula formation? The surgical technique, the timing of surgery, the width of the cleft, surgeon's expertise, and associated syndromes. So what are the classification, the different systems of classification which can classify the palatal fistula? Schultz described as pinpoint, slit, oval, and total dehiscence. Pasumi in 1993 described as grade 1, grade 2, and grade 3. Muzaffar, this is Dr. Percy's classification, our friend from Peru, anterior fistula, middle fistula, and posterior fistula. So the most commonly used classification, the Peterson's classification, it starts from the uvula, type 1, and goes up to the labial alveolar as type 7. So was there any need of new classification? Because we are a very high volume center in the world. My team has operated more than 46,000 cleft lip and palate patients since 2003. So we get lot many fistulas from all around Pakistan and even from Afghanistan, even also from abroad as well. So we got many fistula which were quite large, placed laterally or more anterolaterally, or multiple fistula, or fistula which traverses into adjacent regions. So we developed Pakistan Comprehensive Fistula Classification, a novel scheme and algorithm for management of palatal fistula oblique dehiscence, and this was published in PRS in January 2019. So this was the paper published in 2019. So what the classification should describe? It should describe where the fistula is located, whether it is single or multiple, the size, the velopharyngeal competence, and guidelines for management of the fistula closure. Our scheme is based on location, size, velopharyngeal competence, and dehiscence. So this is our classification. Midline fistula, the blue ones are the lateral fistula. We divided the hard palate into anterior half and the posterior half. So midline fistula is within 5 millimeter on either side of the midline. And when it is more than 5 millimeter away from the midline, we call it lateral fistula. Subtotal fistula, when it involves eh, at least 50% of the anterior part of the hard palate mucosa, we call it subtotal. It may be unilateral or it may be bilateral. So these are the midline fistula. We start from the labial alveolar region, then we go to lingual alveolar, then we divided the hard palate into two, anterior half, posterior half, M2, M3, junction of the soft and the hard is M4, soft palate M5, uvula is M6. These are the lateral fistula, LA, RA, RB, LB, and if it is in the soft palate, it will be RC or LC. Subtotal right, when 50% or more of the anterior hard palate mucosa on the right side has been lost. Same is FTL. When both have been lost, we call it FTB. We also describe the dehiscence. If July dehiscence, we call it D1. If it extends into the soft palate, we call it D2. Extending into posterior half of the hard palate, we call it D3. Anything anterior to it is D4. So we describe the size of palatal fistula 1 to 5, more than 5 to 10, 10 to 15, and more than 15 millimeter. We describe the function of the soft palate. If the palate length and function are good, we call it V1. Palate length is good, but with poor function, that means the muscles have not been dissected and repaired properly. When both palate length and function are poor, we call it V3. Multiple fistula, we call it MF. Then F1 will be the most anterior fistula. And then we write F2 and F3 and we describe the parameter of each fistula. You can see M3, 4, 5, that means it is involving the M3, 4 and 5 region. You can see the multiple fistula, M2 and M4. Multiple fistula, FTB, subtotal bilateral, M3 and RC, subtotal, M3 and RC. Lateral fistula, LB, this is LA, RC, fistula in the soft palate. Subtotal, bilateral, dehiscence involving the uvula and the soft palate, and extending into the posterior half of the hard palate. Dehiscence, uvula, soft palate, and posterior half of the hard palate, but we write as dash L, that means the left side of the palate has been damaged very much badly, that means the pedicle has been lost. D4R, the right side of the palate has been damaged very badly. So the classification should describe information about detailed anatomic description of location, size, and it should provide guidelines with more emphasis on functional imbalance of the palate repair. Why the fistula needs to be closed? We want to avoid nasal regurgitation. We want to have good speech production. How we can close a palatal fistula? Single layer, double layer, or 3 layers. There was a paper in Journal of Maxillofacial Oral Surgery in 2009, and they described single layer closure of the palatal fistula using anteriorly based dorsal tongue flap. I usually do not like this approach, and I feel it can lead to multiple recurrent fistula. So 2 layers are the nasal layer and the oral layer, and 3 layers when we also it involve the soft palate. So we also bring the muscle in between the nasal layer and the oral layers. Nasal layer closure is the foundation pillar of closure of the palatal fistula. Nature has not provided good blood supply to the nasal layer and it cannot sustain on its own. Nasal layer is like a parasite which survives only when a well vascularized oral layer covers it completely. If the blood supply of the nasal layer had been good enough, closure of palatal fistula would have been damn easier and quick. Just close the nasal layer, that's it, and go back home. Some friends have used acellulodermal mattress and conchal cartilage in difficult cases where they feel difficulty to close the nasal layer. However, we have not used these in any of our patients as we feel that nasal mucosa can be closed in all cases with little more undermining. Oral layer is the mucoperiosteal flap which is based on greater palatine artery. The soft palatal portion is based on anterior and posterior branches of the ascending palatine artery. If the oral layer is deficient anywhere in the palate, especially in the midline or anteriorly, it can lead to fistula and descent. What are the resources of alternate oral layer cover? We can use buccal sulcus mucosal flap, we can use fan flap, dorsal and ventral tongue flap, buccinator, and free flaps. And our algorithm, it can cover every fistula of the palate. It can enable the surgeon to achieve good function of the palate, not just closing the hole. So this is our algorithm for the midline fistula. Algorithm for the lateral fistula, RA and LA, RB and LB, RC and LC, and then subtotal fistula. The longitudinally placed fistula in the midline are closed comfortably by palate repair. However, transversely placed fistula located anywhere pose more difficulty and may or may not need additional tissues for oral layer cover. Subtotal bilateral fistula always needs additional tissues for coverage like buccinator flap, tongue flap, buccal sulcus mucosal flap, or bilateral fam or free flap. So, what is the management strategy? If there's any fistula and the velopharyngeal function V1, just close the hole. If the velopharyngeal function is V2, we need to do palate repair plus levator dissection and retropositioning. If the V function is V3, then we need to do the palate repair. We can add pharyngeal flap or we can do sphinctopharyngoplasty at a later stage. So now we come to midline fistula. So different fistula M1 to M6. So you can see M2 fistula. So we close the nasal layer to cover, to provide oral layer cover, we use the buccal sulcus mucosal flap. You can see it is being transported through the alveolar cleft. It has been sutured, healed nicely. We added pharyngeal flap as well. M2. So we will use turn-in flap for nasal layer closure. We will do palate repair. So we raise both mucoperiosteal flap, close the nasal layer, and put back the mucoperiosteal flap 2 months later. Palate, this is M3 and palate repair. Late follow-up, M4 and then V3. So we did the palate repair and we added pharyngeal flap at the same stage after 4 weeks and after 6 months. M3, F2, V3. So we did the palate repair. We added the pharyngeal flap at the same stage. We only made incision on the right side. And because we do the radical section of pedicle, so we can move the right flap to the left side. So late follow-up, you can see the pharyngeal flap healed. M5. So we did the palate repair. fistula adjacent regions M1 and M2. So we close the nasal layer and we use the buccal sulcus mucosal flap for oral layer cover. Another patient M1, 2, 3. So we use the buccal sulcus mucosal flap. We need to emphasize the good oral hygiene. Otherwise, we cannot see the buccal sulcus mucosal flap or the portion of this palate where we have applied any flap. M2, 3, 4. So we use the nasalar closure. We raise both mucoperiosteal flap. Late follow-up M3, 4 because it is V3. So we did the palate repair, re-repair in the first stage. This is our old series patient. Then we did the pharyngeal flap as well. M3, 4, 5. So we did the turn in flap for nasalar closure and we did palate re-repair for the oral layer cover. This is late follow-up. So M4, 5, we did the palate re-repair and we added pharyngeal flap at the same stage. M2, 3, 4, 5, did the palate re-repair, added pharyngeal flap at the same stage. So M2, 3, 4, 5, we did the palate re-repair. This is late follow-up and 6 months follow-up. Multiple fistula. M2, 4 just did the palate re-repair. M2, M3 and D1. So we did the palate re-repair in the first stage. So multiple fistula M2, M5 and D1. So we did the radical section of the pedicle on right side. We did not make any incision on the left side. We just did all the dissection from the medial side. You can see the pedicle dissected widely. Then we dissected the levator. We raised the pharyngeal flap. Pharyngeal flap has been turned anteriorly. Now you can see pharyngeal flap being attached on the left side and on the right side of the soft palate. Levators have been sutured together at the base of the pharyngeal flap, taking a good bite of the posterior superior constrictor muscle of the pharynx at 3 weeks and this is at 2 years. And the patient's speech is very good. Multiple fistula M3, LA, RA, RB. So we planned the turn-in flap and palate repair plus pharyngeal flap. So we did this. We are showing the fistula location with periopteral elevator. You can see the pedicle dissected and ultimately oral layer put back. But probably the pedicles were damaged in the previous surgery, so we got bilateral necrosis of the mucoperiosteal flap. So then we did the debridement and then we put the patient on honey and honey and honey. And this area healed with fistula again. So these are the fistula and the second phase. So then we closed all the fistula. Then we used dorsal tongue flap. This is after at 1 week post-operatively, 2 weeks post-operatively. This is at 1 year follow-up. Lateral fistula, LA, RA, RB, RLB, LC, RC. You can see LA. The velopharyngeal function is V3. So we will close the fistula. Use the right mucopharyngeal flap to cover the suture line of the nasal air closure. We will add a pharyngeal flap as well. You can see the pharyngeal flap marking. The right flap has been raised. The nasal air has been developed. Now you can see follow-up at 3 and 6 weeks, before and 6 months after surgery. Another patient with LA, we did not use the marking on the right slide. We used another technique. We raised both the flaps. Now you can see the extent of the nasal defect. So we close the nasal layer. You can see the nasal layer closed. And then we put back the lengthened mucoperiopteral flap. We lengthened the mucoperiopteral flap. You can see this portion was lengthened, and we put it back at 3 months. And at 6 months after surgery. Another patient with LA, S4. So we use the right mucoperiopteral flap to provide cover. The left flap has been dissected, right flap has been dissected, and both pedicles have been dissected. The nasal air is being closed, and we have dissected both levators, and we put it back very near to the uvula. Now you can see the late follow-up. We also did some lip nose revision over here. Another patient with LB, lateral fistula in the posterior half of the hard palate. Pharyngeal flaps were done by someone already. So just try to close the fistula with the local tissue. So it had the worst outcome. So we had a recurrent fistula which was larger than before. So it was like after one surgery it became bigger. So nasal secretion was pouring into the oral cavity. So then we decided to use the right mucoperiopteral flap for oral air cover. And you can see the nasal air closure. Now you can see the pedicle dissection. Only pedicle dissection can allow the right flap to go to the left side. We left it open and it healed nicely. So before and after 1 year. Another patient with fistula on the right side of the posterior hard palate. So we are going to use the left mucoperiopteral flap to provide the cover. We are also going to add pharyngeal flap at the same stage. Now you can see the nasal air developed. We already dissected the levators on both sides. We are going to raise the pharyngeal flap. And now we are pushing the pharyngeal flap on the with the soft palate area. The pharyngeal flap has been raised. The donor side has been closed primarily with running continuous suture. Now the pharyngeal flap has been sutured to the right side and now on the left side as well. Now the left flap is going to provide cover. On the right side, you can see the pedicle dissection widely. So we put gelatin foam on the left defect. 4-week follow-up and 6-week follow-up and 24 weeks follow-up. Fistula on the right side of the soft palate. The palate length is quite short. So we did a pharyngeal flap and palate re-repair at the same stage. After 24 weeks. Fistula on both sides, RA and LA. You can see a periafter elevator going through both the fistula. Then we made an incision over here. We raved the whole the palate as a one flap. Now you can see the extent of the nasal defect. So we develop the nasal layer, we close the nasal layer, and we put back the mucoprotective flaps, and we could have some widening on both sides. 3 weeks follow-up, 24 weeks follow-up, 30 weeks follow-up. This patient has been operated 5 times previously. Large fistula anteriorly. You can see with the Dingman in. So we closed it in double layers at 10 days. At 7 weeks post-operatively. I can share the video. How did we do it? We are going to develop the nasal layer first on the left side. So we are developing the nasal layer on the right side. We are opening the flap as a wide. Now we are going to close the nasal layers on both sides. Nasal layer is being closed on the right side now. We also close the defect in the alveolar cleft as well. So now we are going to suture it. Now we go to subtotal fistula and descents. So subtotal left when left pedicle is damaged, subtotal right when right pedicle is damaged, and subtotal bilateral when both the pedicles have been damaged. Now it's algorithm. Subtotal left, we are going to use the right mucoperioptic flap to provide the oral layer cover. Subtotal left, we use the right mucoperioptic flap to provide oral layer cover on the left side. FTL and M2345 large fistula. We use the left vaccinator to provide oral layer cover, and this is 3 weeks follow-up, 3 and 6 weeks follow-up, 3 months follow-up, and at 6 months after this surgery, we added the pharyngeal flap as well. So at 2 surgeries, we could rehabilitate the patient completely. We use the vaccinator as well. We raise the right mucoperiosteal flap because the pedicle is intact over there. Left flap has been lost. So we just use all the tissues for the nasal layer closure. You can see the pedicle being dissected. The right side of the nasal layer is being dissected away from the palatine bone. The left side of the nasal layer has been dissected from under the palatine bone. The nasal layer is being closed. So now we are using some random pattern soft palate tissue to bring into near to the right mucopurchase flap. Now we are going to raise the buccinator flap. Buccinator flap being sutured. Being closed, the lateral defects. We usually try to close the donor defect completely. Now we are going to add a pharyngeal flap after 6 months. Raising the pharyngeal flap from the posterior pharyngeal wall. Closure of the right side of the nasal layer with the right side of the pharyngeal flap. Now we are going to start the oral layer closure. Another patient with FTR, we use the left mucoperiosteal flap to provide oral layer cover. And you can see the late post-op results. Another patient with a fistula on the right side of the hard palate area, we added a right buccinator flap. This is after 3 months. Subtotal right fistula with M2, 3, 4, 5. So we use the turn-in flap for nasal layer closure. We use the left flap for the oral layer closure. And we add a pharyngeal flap in the second stage. So you can see the defect, extent of defect. So we close the nasal layer, we use the left flap to provide cover. Now you can see the left flap has gone almost to the right side, and this is the right side tissue which is random pattern based. This is after 3 months. So then we added a pharyngeal flap to lengthen the palate. 3 and 4 weeks after pharyngeal flap added. And this is before and after surgery. So in 2 stages, we could reconstruct the whole palate and we could lengthen the palate as well. Another patient with FTR, we use the left flap to provide the oral layer cover. You can see the left flap has gone almost to the right side to provide oral layer cover. And this is after 3 months. Another patient, we use the left flap to provide oral layer cover. And this patient is on the title of my book, Surgical Atlas of Cleft, Palate and Palatal Fistula. We use the nasal layer closure and we raise the left mucopurchase flap and we did the dissection of the pedicle very widely. Then we close the nasal layer. We make incision over here, we go up to the bone, and then almost all the mucosa is moved to medially. So we could close the total mucosa comfortably. Then we put the left flap over the suture line of the nasal layer closure. And this is at 6 months. FTB, we use tongue flap to provide the cover. We always believe in nasal layer closure first, complete nasal layer closure. Then we use the tongue flap, and you can see the complete closure of the fistula with the tongue flap. Another patient, we use tongue flap to provide the oral air cover. Now, MRUT, mucosal rugosity unfurling technique. You can see different fistula, large fistula, anterior fistula. So what are the options to close anterior fistula? It may be vaccinator, FAM, free flap, buccal sulcus mucosal flap, or contralateral mucoperiosteal flap. Vaccinator and FAM flap, the dissection is quite difficult and tedious. Free flap will lead to prolonged surgery. Buccal sulcus flap can only be used in alveolar cleft, and contralateral mucoperiosteal flap can only be used when fistula is unilateral. So, what is the pathogenesis of mucosal rugosity? You can see the large defect. So, what we feel is that the granulation tissue grows from here to anterior side, then it goes nasally, and then it goes posteriorly on both sides, and until it contact inhibition by epithelial surface, and the whole of the rugosity gets mucosalized. And then we unfold it like we release the contracture of a finger. Now you can see this patient again. This is the normal marking anybody would do to close the nasal layer. If we close the nasal layer like this, we will need a large flap. Maybe we use bilateral vaccinator, or we use a tongue flap, or we use a free flap. But when we put hooks over this area, we could see two large rugosities. We could open the rugosity on the left side. Now you can see the length of the left mucoperiosteal flap. We did the same on the right side. You can see the lengthening of the mucopurulous flap on the right side as well. Now we are going to mark the nasal layer. So nasal layer is being dissected, nasal layer being moved, and it has been closed completely. We are using the left buccal sulcus mucosal flap to provide cover in the left alveolar cleft area. So this is the midline closure. At the end of the surgery, this is at 24 hours. Late follow-up, the palate was short, so we added a pharyngeal flap in the next stage. Another patient, if we do close like this, we will end up with a large defect. But first we raised both the mucoperiosteal flap and we unfolded the mucosal rugosities. Now you can see the nasal layer defect. So now you can see the lengthening of mucoperiosteel, both flap, and we then put the flap again inside like this. That means this portion has been lengthened on both sides. Nasal layer has been closed completely. Then we put back both the flaps. This is after 24 hours. And this is at late follow-up. Another patient with FTP, both pedicles lost. You can see the extent of the defect. We use mucosal Lukafton folding technique, and we use buccal sulcus flaps on both sides. This is the right buccal sulcus flap. This is the left buccal sulcus flap. So this is at the end of surgery, 24 hours after surgery. Follow-up, 1 week, at 2 weeks, at 3 week follow-up. And then we She developed a fistula over here. Now we plan to use the right vaccinator after nasal air closure, and oral air closure, oral air cover will be provided by right vaccinator. Another patient with FTB, we use the buccal sulcus mucosal flaps on both sides. She developed a small fistula over here. Palate length was short, so we did the fistula closure, and we added a pharyngeal flap at the same stage. Fistula closure, pharyngeal flap added. So if somebody says my results are 100% excellent, he can be in the simulation lab. But when we operate, we always get complications. Now this is the patient, we use the mucosal Augustian folding technique, we develop recurrence. So another patient with multiple fistula. So whenever we want to use the tongue flap for the palate repair, we need to see the tongue flap mobility as well. So in the first stage, we release the tongue. Second stage, we close the nasal layer. Nasal layer completely closed. Now you will see we are going to use the tongue flap. We use the tongue flap for the oral layer cover. We still have two fistula to be closed. Either we can use fan flap or we can use vaccinator flap. But we plan to use extra tissue from the tongue during detachment to cover the remaining fistula. So this is the extra tissue taken from the tongue and you provided cover, it became dusky. Distal portion of the flap got necrosed, but ultimately it healed uneventfully. So we could cover 3 fistula with 1 tongue flap. You can see 3 fistula covered. Now we come to the last portion, descents. D2 palate repair. D3 palate flap. Another patient D3L. So we are going to use the right flap to provide cover. Right flap has been raised. The nasal layer is being closed. Nasal layer closed completely. Elevator defected. You can see the elevator sutured. The right flap covered the nasal layer suture line. After 48 hours, after 6 weeks, and this we added a pharyngeal flap. So we started from here, ended up over here. Another patient, D3R right flap has been lost. So we will use the left flap to provide cover. Now the left flap has been raised, pedicle defected. Now you can see the incision over here. The posterior portion was used in the nasal layer cover. We did not make any incision over here to keep the blood supply intact. So the pedicle has been dissected. The left flap would cover the suture line. You can see the left flap has gone over here at 3 weeks. We lost the patient for pharyngeal flap. D4R, very extensive defect. So we use the left mucoperceptive flap to provide, you can see the dissection of the pedicle, very wide dissection. The nasal layer has been closed completely. The left flap put exactly over the suture line of the nasal layer closure. Late follow-up, healed palate. So because the palate was short, so we added a pharyngeal flap to lengthen the palate. Pharyngeal flap added. 24 weeks follow-up. So from this position, we went to here, complete closure of the descent. We could lengthen the palate, and this is 6 years follow-up. Another patient we did 4 months back. We used the left flap to provide oral air cover. You can see 1 week follow-up, 3 weeks follow-up, 5 weeks follow-up, 9 weeks follow-up. We will add a pharyngeal flap at 6 months. The last patient I'm going to share with you. I was invited to Karachi to operate a palate patient. I thought it was a wide palate. When I started operating, I came to know it is complete descent. So I could develop the nasal layer on both sides and try to close the nasal layer. You can see the very thin mucoperipheral flap on both sides. You can see the nasal layer being closed. Nasal layer has been closed completely. The mucoperipheral flap has been elevated, and the pedicle has been dissected on both sides. You can see the pedicle dissected. Now I started closure of the midline. Started closure of the midline. Midline closure completed. Very tiny, thin mucoperipheral flap. We put gelatin foam on both sides. This is after 1 week. At 4 weeks follow-up, he started developing a fistula in the midline. 4 months, he developed a large fistula in the midline. And my colleague in Karachi did the palate repair. Now you can see before and after the first stage, the second stage. So we could completely close the palate completely. This is our hospital in Lahore, and where we provide training to surgeon, anesthesiologists, orthodontists, and speech pathologists. We have surgeons from UK, Afghanistan, Ukraine, Poland, Germany, Ethiopia, Tanzania, and Congo. And this is my friend from Ecuador, Edward. He have developed 6 WhatsApp groups where we discuss cleft palate cases in different categories. So if anybody wants to join these groups, they can use my WhatsApp number and send their number in my inbox. I can add them to these groups. Thanks very much for your patience. And life is good with friends. The picture was taken in Edinburgh, July 2022 in UK during the Cleft Congress. Thank you very much.
Thank you, Ghulam. It's fantastic to hear you talk, and it's good to see that so many people are still here and listening to you. You've got so much to say. I think if we ask you to talk the whole afternoon, you will still not have enough time. Do you still have some time for questions? I know it's nearly 9:30 in the evening. Do you still have time?
Yeah, anytime.
Okay.
No, I'm free.
You are free. Good. We have a couple of questions, and I wrote some of them down for you. One of them is, what's the indication for the use of the pharyngeal flap? Sometimes you only do the mucoperiosteal flaps, and sometimes you add the pharyngeal flap. Can you tell us a little bit, how do you decide when to do the pharyngeal flap in the same surgery that you close the fistula?
Yes, some of my patients, which were from our initial series, when we were not that much experienced with dealing with cleft. So initially, we usually do the fistula closure in the initial stage. And then after 6 months, we added the pharyngeal flap. But now, because we are now more experienced, so we can add pharyngeal flap at the same stage. But many of our friends, they are afraid of obstructive sleep apnea, because they feel if we use pharyngeal flap, it can lead to sleep apnea. But what we do is, we take 60% of the width of the pharyngeal wall as the base of the pharyngeal flap. That means we leave 20% on both sides for breathing. We do not go beyond 60%. If we go beyond 60%, we will get sleep apnea because the breathing space will be narrowed. So
And how do you, Gul, I'm sorry to interrupt. How do you decide on the 60%? What do you measure?
Yeah. Because now we are quite experienced, but initially when we could measure the width of the posterior pharyngeal wall, and then the middle 60% of the width we will take as the pharyngeal flap.
Okay.
So
Measure it.
only in 2 patients I had to go back. In one patient there was false passages. When we opened the passages, he became all right. In another patient, while the patient was in recovery, my anesthesiology in the recovery, they will always check when they receive a pharyngeal flap patient, they will keep the lips closed, whether the patient can breathe through the nose comfortably or not. If the patient cannot breathe through the nose comfortably, we will bring the patient back to the OR and see what is the wrong. If we have put some suture in a wrong way, we will redo it. Otherwise, we do a pharyngeal flap even in missions. We do not have any problem of sleep apnea.
Okay. I think you have operated on these patients quite a lot. The volume that you measure or that you mention is really incredible. I must say we try to stay away from pharyngeal flaps as much as possible, but I presume it sounds like you do many of them. I think if you stay to the 60% rule, maybe the obstructive sleep apnea is just way less. There's another question about undermining. Can you describe a little bit what you do? And like you say, the nasal layer is crucial. How do you do the extensive undermining on the nasal side? Can you give us some tips and tricks about that?
Yes, I can show over here, because if this is the medial edge of the mucosa, I will make incision over here. Then I will put my elevator under the bone. If I can feel the bone comfortably, that means I'm in the right plane. If I am not feeling the bone, I'm not in the right plane. And then slowly and gradually, you can see the nasal mucosa will be shifted medially, again on both sides. So we make incision right up to the bone, and then we release the mucosa, and then we go under the bone, we go laterally, and then we push the mucosa medially to the midline.
And one kind
Maybe I can share a video with friends in the group where they can see how we develop the nasal layer in large fistula.
Oh, that would be good. Yes, thank you. And what instrument do you use for the undermining?
Actually, when maybe I can also share the pictures of our perioperative elevator. These are made in Pakistan, and the instrument on the palate table are, I think, not more than 12. It
Okay.
includes the scissor, it includes the needle holder, and it includes the elevator, everything. They are very simple, but they are very helpful. Very helpful.
Good. I have another question. We see a lot of patients that are not young anymore. Does that mean that many patients are operated at a late stage in your country, or do they just present very late before they reach you?
No, actually, the problem is in many of the villages, they have a myth. They feel that this defect was from God and you should not get operated, otherwise, God will become angry. So, many of the patients, they have not been operated up to 60 years of age. I have operated more than 50-year-old cleft palate, never operated before. So in the villages, in the rural areas, we still have many. We went to northern area of Pakistan in 2017. We operated 3 ladies with cleft lip. They were 55, 65, and 70 years old. And they were married, but they did not go to any family ceremony except their own marriage because they were considered not good human beings. And we repaired their cleft lip and they were restored to normalcy.
Yeah, wow. And why do you think many of the patients that present to your unit have these anteriorly placed fistulas? Because it looks like um, it's obviously surgical technique of what the surgeons use, but it looks like there's a lot of problem trying to get healing in the anterior place of the palate. Why do you think that is?
Actually, question like you are a professor of pediatric plastic surgery. You are not a professor of aesthetic surgery because you chose a field for yourself. Fortunately or unfortunately, every plastic surgeon cannot be a good cosmetic surgeon. Every plastic surgeon cannot be a good cleft surgeon. He cannot be a good microsurgeon. So many of the surgeons, they are not well trained in cleft surgeries. But because there is no uh, regulation or there is no regulatory authorities, so anybody can do the cleft. And the problem is they cannot respect the pedicle. Most of the time they will respect the damage the pedicle, they will get bleeding, they will use cautery and they will damage more tissues, especially when the palate is incomplete. It is also getting some blood flow anteriorly, and if they damage the pedicle, they repair the pedicle. So we are not sure the pedicle has been damaged in the previous surgery. But when we, in the second stage, when we raise the flap anteriorly, we see there is no pedicle behind. So probably most of the surgeon, they can dissect the pedicle, they can see the pedicle very comfortably, they will respect the pedicle, they will respect the surgical anatomy. But some of the surgeons, they are not capable enough, they are not trained enough to see the level of the pedicle, and probably they damage the pedicle, and the anterior fistulas are the outcome of those bad surgeries.
And I presume most of them use a two flap surgery then, right? So they do, yeah, okay, that makes sense. Okay, I was just wondering, you know, because Pakistan has so many clefts, it could be an option that if people include the vomer flap in the primary lip surgery, some of the hard palate will be closed and the secondary palate surgery will become much easier. But that's a different topic. I have a question from Dr. Percy Russell. Thank you.
I have a friend from Peru.
Yes, exactly. He has a question about, have you used the lower turbinate mucosa for nasal mucosa closure during fistula repair?
No, no. I have used the inferior turbinate in nasal air closure for the for the for the nasal floor during cleft lip repair, but I have never used in the nasal air closure because I can undermine the nasal mucosa from lateral side, and I probably we have not a single patient in our series where we were unable to close the nasal mucosa and we were forced to use turbinate flap or something else.
Okay.
No, not at all.
Okay, so there are just so many questions. I'm sorry, we cannot discuss all of them, but this is an interesting question about the buccal sulcus flap that you've mentioned a couple of times.
Yeah.
Jan Nguyen is asking, he says he's been using that as well. Do I need to divide the pedicle for an alveolar bone graft?
Yes, because when you need to do the alveolar bone graft, maybe you have to cut it because you have to because this is a thick flap, relatively thick flap. It is different from the uh, gingival mucosa. So when you want to do the ABG, maybe you have to cut the pedicle. No problem.
Yeah, yeah, I agree with that.
But at our center, we are shifting now to GPP instead of ABG. And we feel that the results of gingiva periostoplasty are quite good as compared to ABG.
And you do that during baby age?
No,
right?
no, not at all. We always do at 8 or 9 years.
Okay, all right, thank you so much. There is a question about speech, right? Obviously an important factor, and like you said, you often include the pharyngeal flap. Chetty is asking a question, and he says, again, also amazing presentation. Thank you so much. Thank you for sharing. Could you tell us a bit about how you measure the speech function afterwards?
Because we have a dedicated speech pathologist in our team. All the patients where the palate has been operated and there's a speech problem, where there's a fistula or not, they all patients go to the speech pathologist. He will examine all these patients, will record the speech sample, and then he will advise us. Sorry. Then he will advise us, Fayyaz, don't do anything. I can improve the speech only with speech therapy session. Or he will write to me, please go ahead with pharyngeal flap, and then I can take the patient, and then I will improve the speech.
Okay.
So whenever we do the mission in remote areas, at our speech pathologist goes with us during before the surgery. He will examine all the patients. Then he will go back at 1 month and at 3 months to examine all the palate patients and to guide the families how the speech can be improved.
Thank you. Great. Yeah. Good. So the big answer is include your speech pathologist in the process. Very, very good. We see that there is a lot of big lateral incisions that you use. We don't see a lot of buccal fat that you use to close that space up. Are you against the use of buccal flaps?
No.
Actually, I'm talking about buccal. The question, buccal
fat pad flap. Yes, I agree. Yes. Now we are using buccal fat pad flaps in many of our patients because many of these patients were from a previous series. Now recently, I am more and more using buccal fat pad flap in almost every palate repair so that the healing can be enhanced.
Yeah, I agree. I actually do the same only the last 2 years. I didn't do it in the past. There's a question from Luca from Milano. And when I see
our friend from Milan. Hi, Luca. Hope you are fine.
We must make some advertisement for the European Cleft meeting.
Yeah.
Dr. Ghulam Fayyaz will also again be talking. So
yeah.
But Luca has a good question. He said, do you prefer using vaccinator or fan flaps? Superiorly based or inferiorly based fan flaps? And
actually,
some tips about indications.
I have never done a fan flap so far. We started vaccinator probably 2 years back, and now probably every month we are doing 2, 3, or 4 vaccinator flaps in our secondary patients. I have never used fan flap, and I have never done any sphincter pharyngoplasty because I am very comfortable with the pharyngeal flap.
Okay, thank you so much. That's a good answer. So that's why you asked me to write a chapter about the FEM. That's in your book. That's okay, no problem.
Yeah.
But that was good. That was fun doing.
Yeah.
All right, so Oscar, we have a question from Kampala. So Oscar says, thank you for the presentation. I have 2 questions. Is there a cutoff for the cleft palate that you anticipate fistula? And is there a role for the foamer flap? Sorry, let me just repeat it. Is there a cutoff width for the cleft palate that you anticipate on the fistula? I'm not sure. I think he wants to know if you have, if you can anticipate in the baby age to close it in 1 stage or 2 stage, maybe.
Actually, maybe when we get a wide cleft palate, because I have a paper on wide cleft palate in the Milan Congress. We do wide undermining of the nasal mucosa. We even include a part of the oral mucosa into the nasal mucosa so that we can get a comfortably closed nasal layer. Then we do the radical dissection of both pedicle so that the mucoperipheral flap can be brought into the midline for the oral layer cover.
Thank you. Yeah, that's exactly. All right. I have 2 more questions 2 more questions that we have time for. I'm sorry. The one is about the GPP. That is not the whole reason we have this presentation, but it's an interesting question. So let's ask that about the GPP at about 8 to 10 years of age. Yanan Malik says, how do you make sure the gap is narrow enough for the GPP?
Actually, we studied GPP probably 7-8 months back. My teacher, Professor Philip Chen from Taiwan, he has been doing GPP for many years, and we had a lecture in March with Dr. Fong from USA and Professor Philip Chen from Taiwan and Eric Liu from Taiwan. And we sincerely feel that if we do GPP, we can get good bone formation in the alveolar cleft area, and we can avoid donor deformity and prolonged pain in the donor area on the iliac cleft area. So we feel comfortable with GPP, though we do not have a long-term result at our center, but we feel that it can replace ABG comfortably.
I think that's a great answer, and we're looking forward to the results. Obviously, there's a lot of research being done about GPP and also about using beta tricalcium phosphate, maybe just to fill up the space instead of using an alveolar bone grafting, right? So there's a lot of development in the alveolar bone grafting patient group. I'm going to finish with a question from Hoda Obeya, and she says, one question, do you think it's mandatory to do a vomer flap during lip closure? Now, it's a personal technique, I think, but I'm curious what your answer is. What do you think?
Actually, because we are a very high volume cleft center, practically it is a good technique to use vomer during the cleft lip repair so that the hard palate area is already closed. But because we are a very high volume center, we have a lot of workload. So generally we started using vomer flap, but because the workload was more and more, so now we only do the lip repair. But when we do the lip repair, we always reconstruct the nasal floor. And when we do the palate repair, we close the palate completely and we do not leave any intended fistula at the alveolar cleft area.
I must say, just to finish off, I started doing vomer flaps many years ago, and it definitely looks like it does make the cleft palate closure easier. So maybe although your initial surgery is longer, it might make your palate closure a little bit easier. So that's a discussion always, right?
Yeah. You are right.
Yeah.
Right.
And well, all right, we've had many questions that I could not answer, but I'm so grateful for you, Ghulam, for joining us. We keep on learning from each other, and that's, I think, the thing. As long as we realize, all patients are different, and we have to, it's not just a surgical technique that we mention. There's so many small things that we just cannot mention or discuss in a presentation like this that make a big difference. I again heard about the medical grade honey. And I think that's something that we do not have we must have it in the Netherlands, but it's something we often forget about. But it was so nice to hear you talk, and I'm so grateful that so many people were reached, and I'm still grateful that so many people are still listening to you. So, Ghulam, I want to say thank you so much for giving your time again to this and helping us teach other people. I'm looking forward to meeting you in Milan next month, maybe other people as well. So have a good
I would again apologize for weakness on my behalf so that we could start late. I'm sure everybody will forgive me for my weakness.
We will definitely forgive you. It just shows that you are human as well, just like us.
Thank you. Thank you very much.
Thank you so much. Have a good evening, everybody.
Thank you. Have a good time.
Likewise, and thank you everybody for joining.
Yeah, thank you.